The seated lateral adjustment is particularly effective from about C5 to about T2, T3. And that corresponds with the areas that the brachial plexus nerves come out of. So you can see why that actually triggers numbness and tingling. Another thing that'll make you have some one of the things that'll really hang you up with the seated lateral is if you have an anterior vertebrae. So that's also something to check with, because if the vertebrae is a little anterior, it'll give you a pinch on the nerve. So be a little bit careful about that, but it's a very effective adjustment, and it works the best I've ever seen on numbness and tingling in the hands. We're going to talk about something that I found to be a very important concept in my treatment of patients, and that is the anterior vertebrae. The anterior vertebrae creates some of the most painful problems that a patient will have. If you have a patient that drops to the ground on the floor and can't get up, always suspect anterior vertebrae. It's usually anterior L5, usually anterior sacrum, usually lumbar though, usually. So before you even start, you can pretty much know by the severity of the pain that you've probably got an anterior vertebrae on your hands. When a vertebrae moves forward, something like this, it puts a special kind of spinal cord pressure on the spine. It actually brings spinal cord pressure, especially in the sensory areas, into play. So that's one of the reasons why I believe that the anterior vertebrae creates such havoc and this is the most intense pain. When you have a pinch in their neck, it's usually gone anterior on the side of the pinch. If you have a bad pinch in the low back, it's usually gone anterior on the side of the pain. So you always want to be mindful, because the anterior vertebrae is like a little minx in there that gives people some of the worst pain. And if you know that, then you'll be able to correct it confidently and have the patient out of pain by the time they get up off your table. It's pretty amazing when you put them back in how fast the pain goes away. When you're working on a low back, one of the easiest ways I've found to address the whole situation with a low back problem is to break it down in pieces. I usually break it down into pieces, and the sacrum is the main base of the spine. So the first thing I usually address is the sacrum. The sacrum can go sacral apex left, sacral apex right. It can go right posterior or left posterior. And it can also do this, where it goes anterior on the top and pops up on the bottom. So there's several different things that it can do that it generally will do. And if you address each one of these things on the sacrum, you will actually be able to correct your whole low back lumbar problem. The other piece is the ilium. Since they come together, especially if you have a sacral pinch, a pinch in the SI joint, part of the problem is usually that the ilium has gone IN or EX. This is IN, this is EX. So whatever happened when the person was injured, when they got injured, their pelvis will fixate in that position. So if they were leaning too far forward, they may fixate with an IN ilium, and sometimes if they're leaning way out there, they'll actually pop this sacrum up, so it'll go anterior across the whole top. So they'll point to across their whole top of their sacrum as being part of the source of the pain. So when you break it down into pieces, you always check the ischium. You want to check the ischium because that'll tell you whether you have an AS, if one's really sticking up on one side, and you want to check the ilium for INEX rotation. You want to check the sacrum, and you want to turn the patient over. You do the ilium from the side, and then you want to turn the patient over and address the anterior vertebrae and the anterior side of the sac. So when you actually do that, I'm going to show you how to adjust an anterior vertebrae, but you want to be picturing adjusting across here and down in the front of the sacrum. If the lumbars are anterior, you're going to adjust up the front. When I suspect a patient has an anterior vertebrae, I usually place them on their back, and I'll show you a special way to test just for that. I put my hand underneath their low back, and I bring their arm up and have them do the little test, and I actually push the vertebrae up. I showed you on Boney earlier how I push the vertebrae up. So we're going to push that vertebrae up, and you can see she actually has a little bit, well, they're down there, L5. Okay, so she actually has an anterior vertebrae at L5. So I confirmed that with my testing system. And then the way to correct that, I'm going to show you how to correct it. And I'm going to have the patient bring both their knees up because that kind of relaxes the muscles in the stomach. And we're just going to push all the way down to L5. You're going to have to, you can actually put your other hand on L5 and you can try to bring them, figure out exactly where to bring them together. So you're only working on L5. You want to get right on the front of the vertebrae that's anterior. And you're going to push in all the way down as far as you can and keep your arms straight and cock the drop. Again, setting the drop as light as you can because that's really important. You don't want to put too much force on this and you don't want to hurt anybody when they first, you don't want it to feel tender. So you bring that down, you bring your hands in, I use my thumbs, you can use your fingers, you can I use my thumbs and I actually let the table drop and do the work for me. So you can see I'm not doing any of this pushing kind of thing. I'm going down and staying straight armed like this and letting the table do the work for me. So the table's actually dropping and setting that vertebrae back where it's supposed to be. Like that. So I'll do a couple of drops and then I'll go back and test again. Push up. Now see, she's really strong. I can't even put her arm down now. So I corrected that vertebrae. It tells me that she's corrected. And that's another thing you're going to notice. Once you correct it, people's strength it goes bananas. It's like they get very strong. When you go back to test them again, they'll be like very strong. So that's another confirmation that you've actually corrected the problem. So once you've corrected the problem with the drop, you need to go back and post-test. So what I do is I go back and do the same test over and 2 fingers, push up. See, she's very strong now. I can't even push her arm down. That's another thing that you're going to notice once the problem is corrected, that people's strength improves exponentially. They are much stronger, just very markedly stronger when you go back to post-test. Anteriors can occur in any part of the body. Sacroiliac, as I talked to you about, goes forward. It'll give you that pinch. Pubic bone can go anterior. Boy, does that hurt. It goes all the way down the inside of the leg. Pubic bone is another one that we correct. It can go anterior. Pubic bone can go anterior. It can actually cause lots of havoc with, they can't stand on their leg. They get tons of pain. Ribs go anterior all the time. You're going to find a lot of anterior ribs. Once you start looking for them, you're going to see them everywhere. So you can test them the same way. You can put your hand underneath here and you can push up on the rib, or you can actually, the way I test ribs is I do a little movement like this and kind of push them up. So she has a little bit of rib problem on that right side. See, the left side is strong, but when I do this on the right, it's very weak. So she's got some anterior ribs on the right side. Also, neck will go anterior. So if you want to test for anteriority in the neck, same thing. You can bring the patient's hand up and push forward, push the vertebrae forward. The same thing. She's pretty strong. She doesn't have any real problem in there, but it will show up right away if they have an anterior vertebrae. So these are all really important things to know when you're actually working on the spine, because the anterior vertebrae, as I said, cause a lot of trouble. Another little trick that I use is I use these little closed cell foam pads to pad my hand. So you're going to see me using these a little bit more during the session here. But when I do an anterior cervical, the closed cell foam pads really help to cushion the structures in the neck that you don't want to be affecting when you're doing the when you're adjusting the vertebrae. So with the drop, I usually set both cervical and dorsal together so that they drop together. Again, making it so that it's very light tension. And you find the vertebrae that's involved, like say she's a C5 is anterior, and I've already discovered that through my testing. Then you place the foam pads right on either side of the lamina on the front of the neck and drop it like that. Just gentle, drop it gently and do it a few times and you'll find that it'll correct that vertebrae. So we're going to talk about anterior ribs. You saw me, I tested for her ribs earlier and I found that she had some anterior ribs on the right. So this is another place where the foam pad comes in very handy, especially on women. You want to try to avoid the breast area. Usually when I adjust ribs, I try to stay on the cartilage area in the medial part here and not get on the breast tissue too much. It's a lot easier on men, actually. And the ribs are the same thing. I break them down into pieces. You have to sometimes adjust them from the front, from the side, and from the back. Remember when I showed you on bony how the ribs act as a bellows and they go up and down? Well, they get fixated in positions, usually up. Usually when they get fixated, they're usually fixated in an up position. So when I adjust them, my line of drive is always from superior to inferior. I always try to flatten the rib down as I adjust it. So I'm going to show you on Carol here exactly how I work on the ribs. So she had ribs from about here to here that were anterior, probably from moving my office yesterday. So we're going to put your hand on the medial side of the rib cage here, and just push down. Your line of drive is this way with the ribs. You want to flip them down as you adjust them. So I'm going to do some more adjustments right here. Again, the drop is set very light. There's not a lot of force being put into this adjustment. I'm just actually letting the table do the work for me. Just setting it back down in there where it's supposed to be. Now sometimes the ribs get more involved. Sometimes they'll start individually twisting, and that's another thing. You'll have to get directly on the rib and push it down along the length of the rib like this when you have that. And that's especially true of heartburn ribs. They like to flip around in there, and sometimes you have to like pretty much fine-tune that rib back into place. So we're going to do some more drop on here. I use the flat of my hand. Always use the flat of your hand on ribs. If you get too pinpoint, that's when you get problems with cracking them. So be really careful and do light force and stay pretty flat when you're working on ribs. Don't pinpoint them too much, because that's when you get in trouble. And the most delicate, the most critical part to be careful of is the angle of the rib right along through here. Where it curves the most, that's the place where you might get the most trouble with any kind of rib cracking or something. So be very careful. Just stay really light. Keep your hand very flat when you're working on them. So Carol has had the anterior ribs here, so we're going to adjust those. I just felt that pop. And I'll pop them down in, and then we're going to push up and do the little post test again. And she's so strong I can't even push her hand down. So that tells me that I've got the correction, and then she will be getting the relief she needs.